It's Friday. I'm live, YouTube and Facebook. So it's Facebook Friday. It's YouTube Friday. This is where you get all of your questions answered. Let's do it. So just checking the stream, making sure everybody is working. So far, so good. So you know how this works. Friday afternoons, I sit here for about an hour. I answer your questions. So nobody's on here yet, and if you're watching a rebroadcast later, this might be kind of boring because we're waiting on somebody to come on. So I'll give you a teaser. I'll let you know that there is a new video coming out probably later on this weekend that talks about RH sensitization. So, you may have heard this from your prenatal visit. Hey, your blood type is RH negative. What the heck does that mean? So we're talking about that on the latest video, and we're going to explain to you what that's all about. How does it work? What does it mean? And stuff like that. So I'm seeing a couple of people jumping on YouTube, and also on Facebook. So welcome everybody. It's Friday. It's a live broadcast. This is hey Stephanie. Let me know if you can hear me and you can see me and everything seems like working. I'm assuming it is if you said hi. So hi. Here to answer your questions. Just giving a little tease on the latest video that'll be coming out on RH sensitization later this weekend. Hey there, how's it going? All right, so hey, we're getting some questions on YouTube, so we're gonna go. Let's see. Genesis said had a miscarriage and did the shot, but is it true you won't ovulate after this? No. So I'm assuming when you said you did the shot, you mean you got a RhoGAM shot, and that doesn't affect ovulation at all. If that was your question, if that wasn't your question, let me know. But the idea of the RhoGAM shot is just to prevent sensitization. Yeah, good, okay. The idea of the RhoGAM shot is just to prevent sensitization of a mom who's RH negative. So that's what that's all about. So yeah, cool. Looks like things are working. People are jumping on. So if you guys have questions, feel free to put them in the comments in the chat, and we will get rolling. What are my thoughts on Vitex? Good question. So if I'm thinking correctly, Vitex is one of these just fertility prenatal type pills, if I'm remembering correctly. And I have seen some of the reproductive specialists in the area recommending those. I don't have any information one way or another that they're good or bad. So basically if they have some folic acid in them, that's a good thing. There is evidence that vitamin D supplementation is important. I've got a new video out on that, and that's worth looking at. So if you have about 1,000 to 2,000 international units of vitamin D every day, that's a good thing as well. So if it has a couple things like that in there, then I think it's a pretty good prenatal vitamin. I'm not sure what else is in it. So let me know if I'm on the right track there. Let's see. Had another question here. Do you have to wait one cycle after a miscarriage? So actually, there's data now that shows that the sooner you start trying to conceive after a miscarriage, the faster you'll get pregnant and the lower the rate of miscarriage. So actually, the recommendation of waiting any period of time is really not recommended anymore. So my advice to folks is pretty much bleeding stops, you feel back to normal, start trying right away. Okay, so Stephanie says, how likely might I have another preemie if your first was 36 and second at 32? Definitely there's a risk, and it's hard to give you an exact risk off the top of my head, but I think recurrence rates are somewhere in the 30-40% neighborhood. So definitely there's a risk. So really bigger question, what can you do about it? There are a couple different studies that look at reducing the risk of preterm birth. The major one was using progesterone injections, and those are done weekly from about anywhere from 14 to 20 weeks to get started, and then weekly till about 37 weeks. So that's one thing you can do to reduce your risk of recurrent preterm birth, and that is definitely recommended, particularly somebody who's had a 32-weeker. Another thing you can do is you can look at cervical length with a vaginal ultrasound mid-trimester, so 16, 17, 18 weeks, somewhere in that neighborhood. And if you see that it is shortening, then there are options there in terms of either vaginal progesterone or a cervical cerclage. They've both been pretty much proven to be equally effective. So those are the type of things I'd recommend somebody who's had a history of preterm birth. And of course also just keep an eye out for any symptoms and get evaluated right away if you were to have some. So let's see if anybody's jumping on. Oh, hey, Dee Dee, how's it going? Let's see. What is the recommended dose for omega-3 and DHA? It's a good question, and the short answer is there's no standard recommendation. There actually is not great data that DHA supplementation is actually beneficial in terms of prenatal supplementation. Some of the initial studies where everybody kind of jumped on the bandwagon were actually in supplementing newborns, so giving newborns DHA supplement. And there's some evidence of improved intellectual ability later in life based on that supplementation, but there's not great data in the prenatal arena that says it's actually better or worse. So I definitely don't think there's any harm in taking it. Whatever the standard dose is in a typical prenatal vitamin DHA is what I would recommend. I don't have that number off the top of my head, sorry. So I would look at one of those and maybe just go with that. And I definitely don't think you're causing any harm. There is some evidence of like fish consumption being a good thing. There is definitely DHA type stuff in fish oil, and that's what a lot of these are, is fish oil supplements. So I'd keep doing it, but no exact dose recommended. I'd just go with whatever's in the standard DHA supplement from a prenatal. Okay, we're getting some questions jumping in here on Facebook. So let me see. Amanda says 31 weeks, last days, can hardly keep your eyes open. Like you've had sleeping pills all day. Is there a reason for that? Well, one of them may just be pregnancy. Definitely I hear pregnant people every day just telling me that I'm just exhausted. I don't know what to do. And I tell people sort of the obvious thing, rest more, hydrate, take it easy. If you've never had your thyroid tested during pregnancy, get that checked. We routinely check that in on our prenatal panel. So typically we'd be on that, but it's not wrong to recheck it if you're having worsening symptoms, and also to make sure you're not anemic. So you can develop anemia during pregnancy. You have to expand your blood volume substantially while you're pregnant. You have to expand your red blood cell mass substantially while you're pregnant. That requires additional iron, which is often found in a prenatal. Sometimes it's not enough. If you get anemic, you could get pretty tired. And so that'd be the two things I'd think about. Make sure you're not anemic, maybe think about checking the thyroid. If those are both normal, then I think it's probably more about just rest more. There's definitely all kinds of sleep disturbances that occur when you're pregnant that could lead to fatigue during the daytime, and you might not even realize it, or you probably do, that you're tossing and turning all night long, and that could lead to being pretty wiped out too. So maybe consider those things. Okay, so let's see. Lori says, what are your recommendations for women who've gone through menopause, experiencing hair thinning, lots of hair thinning, frowny face? I've tried everything, biotin, flaxseed, B-complex, iron, thyroid, tested one, doctor suggested male Rogaine, low-dose estrogen option. There's not good data on estrogen supplementation regarding hair loss, so I don't think that I can tell you yes, no, or indifferent on that one. Hair loss is a fairly common thing, and thyroid definitely is the one that, if you read the textbook, says check your thyroid. If your thyroid's normal and you're not iron deficient, then what I suggest people consider is a consult with a dermatologist. They can actually do a scalp biopsy and look at your scalp and see, is this a scarring alopecia? Is it a non-scarring alopecia? Because that kind of leads down different pathways. Sometimes you can see if there's some sort of autoimmune thing going on based on biopsy. So basically, I'd say see a dermatologist if you've tried iron and had your thyroid tested, and maybe get some further evaluation there. Okay, so Jaden, when heating lunch meat at 165, do I have to eat it hot or can I let it cool? Probably okay to let it cool. I wouldn't like heat it, cook it today, eat it tomorrow, that kind of thing. But if you heat it up, you get it hot, and then you let it cool off and eat it 5 minutes later, I think that's totally fine. The idea there is with lunch meat, we're just trying to kill any bacteria that might have contaminated the lunch meat, specifically Listeria. It is heat sensitive. If you thoroughly cook it, it should be fine. And I think it's perfectly fine to let it cool off. Okay, let's see. Megan, can you tell me more about pregnant carrier screen? I know it's optional. Would you suggest it? So the carrier screening testing is, at least in my opinion, sort of controversial. It's not controversial according to our college, the American College or Congress or whatever they call themselves now of OBGYN says we should test everybody. We try to offer it to everybody. The concern is really not so much about the test itself, but the cost. So some insurance is covering cystic fibrosis testing and only cystic fibrosis testing. That's the most common genetic disorder in white folks. About 1 in 20 white folks is a carrier. It does vary by ethnic groups. It is present in other ethnic groups, but most common in white folks. So that's one of the tests. The other that's recommended specifically is this thing called spinal muscular atrophy, or SMA. But what we're finding is that a lot of insurance, at least in our area, are not covering the SMA, unless there is a family history. And so even though, it's recommended as consider this for routine prenatal care, a lot of insurance aren't covering it. I've seen bills from anywhere from $400 to $1,000 for one test. Seems kind of excessive to me. But those are the two most common. Another group of people who really should consider carrier screening, even pre-pregnancy, are a very specific ethnic group called Ashkenazi Jewish people. They have a lot of different ones, and I can't list all of them for you, that could potentially be running in their genes. So they are recommended. There's actually an Ashkenazi panel. So that's recommended. If there's family history of anything weird, then you might consider testing. Problem is, with most of these, if you're already pregnant, it's kind of one of those, what are you going to do? Most people are probably going to continue their pregnancy, even if they learn that both partners are carriers. And there's, in that case, there's a 1 in 4 chance that a child's affected with whatever we're talking about. Most people are probably going to continue that pregnancy. So, you need to do the test up front if you're already pregnant. The most common ones are tested after birth. So CF's on there, SMA's on there, another one called PKU, phenylketonuria is on there, and then a ton of other ones that are on the state panel in Utah, and most states have the same kind of thing. They do a heel prick and draw like a drop of blood from the baby's heel. They drip it onto a little card, let that dry, and send it off to a state lab where they test for all these different diseases. So ultimately, the babies are getting tested anyway. So, to me, it's not a giant big deal that everyone absolutely must do this. I think if it was covered and there was no hassle, then I think it's a great idea. But our experience has been there's a lot of pushback from insurance companies. We're seeing patients get some pretty crazy bills for a test that, ultimately is probably not going to change anything and gets tested after delivery anyway. So that's kind of a long-winded way of saying, yeah, you can do it. Who knows who's going to pay for it or what it's going to cost, and it may not ultimately change anything for you. So I would just kind of consider those types of concepts when you're thinking about if you want to do the test or not. But it's a good question. Get it all the time. Okay, let's see. Lexi says, evening primrose. When is it safe? I wouldn't ever recommend anything to anybody to try to jumpstart labor until they were term, so at least 37 weeks. It's probably not effective. Most of these over-the-counter supplement type things do not work. I think it's okay to try it, but we really don't know much about safety. You don't know much about the purity of what you're taking. In the U.S. at least, supplements like that are not regulated by the FDA, so it may say it has evening primrose oil in it, whatever that is, and it may or may not actually have it. So there was a report within the last year or two that I want to say was published in maybe it been the New York Times, where they looked at these supplements, and some of them were from Utah. I'm not going to name any companies' names, where they tested the actual ingredients in a supplement, and half the time the stuff wasn't even in there. So, you're paying money for something that's not even in there. But short version, I wouldn't do anything before 37 weeks for sure. Okay, cool. Well, let's see if anybody else is going on there. I don't see any questions over here on YouTube. Hey guys, if you have any questions over here, let me know. Let's see. I think I'm caught up on Facebook too. So look at that. We're at a quiet moment. So if you're just jumping on, put your questions in the comments. Happy to answer them either on Facebook or on YouTube. For the moment, I've kind of finished everything off. So I'm just kind of waiting on somebody to ask me a question. All right, hey, good. We're getting some more questions pop up on Facebook. Megan says, I've been trying not to drink caffeine. So every evening getting headaches, could be caffeine withdrawal. I've never personally gone more than about 12 hours without caffeine as an adult, so it's hard for me to say how long does caffeine withdrawal last. But if it's been more than a week or so, I doubt that it's caffeine withdrawals at this point. Now, definitely in the first few days, it could certainly be. There is a video on my channel about caffeine use in pregnancy. There is one study that linked possible risk with childhood obesity. It was dose dependent. There was no dose where there was no risk other than just don't take it at all, although the risks were still pretty small in the lowest dose group, which was like 50 milligrams a day. So let's see. JD says 33 weeks pregnant, last week or so, get nauseous when you lay down, throwing up every night, fall asleep. Any idea what's causing this? Yeah, pretty common in pregnancy just to have those type of symptoms really at any time during pregnancy. It doesn't necessarily matter what gestational age you are, it can happen, and it's probably just that. Now, as you get more pregnant, you got to think a little bit about gallbladder stuff. So if you're having abdominal pain with this nausea, especially if it's after you eat food, and especially if that food is like greasy food, then you got to think a little bit about gallbladder. So in people in third trimester who are having a lot of nausea, vomiting, I will sometimes check some liver function tests, blood count, maybe get an ultrasound of their upper abdomen to take a look at the gallbladder, pancreas, stuff like that. If it all looks normal, then it's definitely just pregnancy. In which case, take a little Phenergan at night to help with nausea. That'll help you sleep, and I think that's safe and reasonable and not anything to be concerned about. Courtney says, has some breast leakage for last month or so, now about 25 weeks. It's really common. I think it's perfectly normal. I don't think it means anything bad. I think it's more common in moms who've had kids before and nursed before. I think that's just kind of like breast tissue going, yep, I know what to do, I'm getting ready. So I don't think that means anything in terms of like for preterm birth or anything like that. Let's see, I think I saw something pop up over here from Dee Dee. Let's see. Are all new pregnant patients drug tested? Probably varies from place to place. We in our prenatal panel or in our information we give to new patients say that's something that might need to be done. It's not universally done. So I think it's kind of more selective. And generally speaking, most places you have to have consent. But I can't talk about everywhere and everybody. Let's see. Yeah, so and without the patient knowing. Yeah, typically not. I mean, usually you have to get consent, but everywhere is different. So rules vary based on where you are. Let's see. Dacry says, can you get your tubal reversed? How's it affect chance to get? Yeah. So short version on that is it depends. Maybe depends on the type of tubal that you had. So the more tubal tissue that was destroyed in the process in the first operation means the less you have to work with now if you want to get it reversed. So that's something that, of course, when you're counseling a patient up front, they're thinking about sterilization. I really try to make a big deal about this is permanent. You should not think that you could get it undone someday. And when I do sterilizations nowadays, we're actually doing salpingectomy. So we're just removing the tubes, and it's extremely permanent. There's no reversal of that. But the reason is that by doing that, you actually reduce a patient's risk of ovarian cancer. So there's a major health benefit, and I counsel everybody on that. If there's somebody to me, if there's someone who doesn't want that done, then they just shouldn't get a tubal because you should consider it permanent. Now, that's not where you are. You're thinking about getting yours reversed. So again, it depends on the type of tubal that was done. If you had little clips, those are the easiest to reverse. If you had cauterization where they burned a big chunk of tube, those are harder. If you had a salpingectomy, it's pretty much impossible. In vitro is still a good option. If you had an Esure, you can do in vitro. You can't really reverse those. So in vitro is always an option. And for a lot of people, actually is the most effective and most cost effective. Because you don't have to worry about, well, if you get the tubes reversed and then you have one baby, well, then you got to get sterilized again, and what that going to cost. And when you add it all up, it may be cheaper just to do one round of IVF. So that's kind of my brief answer on there. Hopefully that answers your question. Kisa, hey, from Ohio. How's it going? Let's see if anybody on YouTube's got anything. No, that looks like I'm all caught up over here. So, hey, if you're just jumping on, I'm just answering questions live here on Facebook and on YouTube. And you can see some of the questions in the comments we've already gone through. But if you have your own questions, put them in the comments and I will fire away. Let's see. It says Nell. Sorry, I can't see it up close. Took an OPK and it was positive, and then 6 hours later it was negative. What would be the cause of that? That's a great question. I mean, hydration status probably is the easy answer there. Sometimes, the amount of urinary luteinizing hormone that you're picking up from a ovulation kit, it's a very low dose of a hormone that they're detecting. So, a lot of them, they'll say, don't test or don't have anything to drink for like 2 hours before you do the test, or do it first thing in the morning. And so maybe hydration status is affecting that. Otherwise, you may have just caught it like as the number was going down. So when you ovulate, when there's that LH surge, there's a peak, and then it falls. And so you may have caught it on the falling, and it just went undetectable, and you just picked it up, as it was on the downside. But I don't think it means anything beyond that. Don't think it's anything to worry about. I would just say sounds like a positive. Positive is a good thing. Let's see. So Stephanie, 4 months postpartum, got the Mirena 7 weeks, still randomly bleeding, just spotting. Any idea what it is? Yeah, it's the Mirena. It's not anything to worry about. So I tell people when I put in an IUD, you may have irregular bleeding for up to 6 months. What it's probably going to be is spotting, and the spotting will slow. You'll get less and less week over week and month over month. But I tell people wait until 6 months to really know. Whatever you have at 6 months is probably what you're going to have going forward. So I wouldn't be worried yet. I'd give another couple months. All right, let's see. Got a couple questions over here. Are there benefits from delayed cord clamping? Yes, Haley, there are benefits from delayed cord clamping. Primarily reduce the risk of fetal anemia. I actually have a video on my channel I think it's in the 3rd trimester playlist that kind of goes into that in some detail, but the gist of it is yes. The standard of care based on the research would be about 1 minute of delayed cord clamp. Seems to strike the balance between baby getting the benefit of the delayed cord clamp but not being exposed too long because there's concern you may develop jaundice if you give the baby too much blood, because then they can't use the blood. They've got to turn it over, and in that turnover process they can develop jaundice. So about 1 minute seems to be a good thing for sure. And let's see, B says am cycle day 19, still no positive PK, first cycle, trying to conceive. Yeah, I mean, it's hard to know from one cycle, so I think it's more important kind of big picture, tracking ovulation, tracking your cycles for a few cycles, 2, 3, 4 cycles, see what's really going on. And then you also check out, there's a video on my playlist that talks about maximizing your fertility. It's under the trying to conceive, fertility / trying to conceive playlist. Cervical mucus monitoring actually is more accurate than ovulation predictor kits, and it's actually free. So if you're getting weird results on OPK, I would recommend maybe look at cervical mucus as an alternative way to monitor. Let's see, what else popped up? Irregular periods, yeah. So probably just not ovulating regularly is what it sounds like. And you need to have an RH surge. You need to have an RH surge not the night before a period. So, the LH surge occurs about 2 weeks before your period starts. So the LH surge occurs, that causes ovulation, and then if you don't get pregnant, you'll have a period about 2 weeks ago. Okay, so let's see. Kylie, is it possible for an IUD to move or fall out? It can happen. And if you have concerns, I'd always recommend just come in and get an ultrasound. It's really easy to figure out. As far as the fallout question, I mean, if you can feel the strings, it hasn't fallen out, but it doesn't necessarily mean that it's in the right position still. So, if you're having a lot of pain or weird bleeding, then it's reasonable to come to the office, get an ultrasound, and just check the position. So let's see. Hey, Ashley, how's it going? Had mastitis. Sorry to hear that. Went to Instacare, got antibiotics, cleared up, could possibly get an abscess in your breast, I'll watch it, blah, blah. We don't typically worry too much about abscess as long as you take the antibiotics and the redness clears up. One of the ways you'd know if you had an abscess, number one, is you'd have continued pain and fever and redness in the skin, and you'd have a lump. They're not hard to diagnose. I mean, usually you can just feel the breast and feel like this getting in there. So that's what I would look for. But if like the redness went away, there's no lump, you feel fine, no fever, you're good. Don't worry about it. Happy to see you in the office. If you're concerned, we can do a quick exam. It'll be easy. But I don't necessarily recommend routine breast ultrasound to rule out an abscess if clinically the patient improves. Okay, so let's see. Jordan says, I have been told these new dark skin patches on your face from hormonal imbalance. Have you heard of this? Let's see. Well, this keeps going for a minute. Let me keep reading. So dark patches on your face, I mean, the one thing that we think about is usually estrogen induced. So it's called chloasma. It's fairly common in pregnancy. It's fairly common if you take birth control pills or other sources of estrogen. But if there's no external sources of estrogen, then it's probably not that. In which case, maybe seeing a dermatologist is the way to go. But if you're taking a birth control pill or something like that, then that would do it. And obviously people who are pregnant, we see this all the time. Let's see. Do you have to ask the nurses for delayed cord clamping? No, I mean, it's pretty much routine, Leah, to do the delayed cord clamp. Pretty much the baby's born. Just put them up on the tummy and let them hang out for a minute. They'll ask you, like, did you have any preferences or anything? Mention it. But it's pretty much routine. But the only time you don't do it routinely is if the baby's in trouble. So, if the baby comes out and is depressed and needs resuscitation, well, we're not going to wait a minute. We're going to just that cord and let them have the baby to work on them. But if things are going good, then just put them up on the tummy, give them a minute. Let's see. Amanda, question on effectiveness of Femera. Yeah, I mean, Femera is, definitely a first-line treatment for ovulation induction, especially for patients with PCOS. Probably just as good, if not better, than Clomid. So we use it a lot, and it seems to work, and I recommend it. Cool. All right, let's see if there's anything popping up over here on YouTube. Let's see. Been trying. Let me go back here. Trying to conceive for 2 years. Never got a positive preg test. Gotcha. Yeah. So, I mean, it may be that, I don't know, you didn't say, but if you're on medication like Clomid or Femera to induce ovulation, sometimes it's helpful to do ultrasound monitoring of follicles just to see if there's development there, especially if you had really irregular periods. So that's something to consider. All right, let's see. Yeah, I think I'm all caught up. Cool, all right, let's see. Ashley, hey Ashley. Next one on placed in May, 2 cycles, a lot of spotting, 22 days total this month. Yep, that's next one on. Hopefully with time it gets better. But I tell pretty much everybody, the number one side effect of a next one on is irregular bleeding. You might bleed every day. That's the usual words that I say. So it's common. It may settle down. One option is to give back a little estrogen, either in a birth control pill or just a little estradiol, to try to thicken up that endometrium a little bit and control the bleeding. Sometimes you can do that for a couple months and straighten things out. So if it's continuing to bug you, you can come in, we could do an ultrasound. If the lining looks thin, then that's something to consider. All right, let's see, Jordan, how long would you suggest trying to conceive before using Femera or something else? So, technically the diagnosis of infertility is a year of trying and not getting pregnant. Now, I kind of mentally at least break that up into folks who are, say, under 30, over 30, just because 30 is kind of one of those important numbers where there's evidence that fertility declines after 30. Now, it's not to say you can't get pregnant, you totally can. But it can be harder. So in folks who are 30 and up, if they've never been pregnant, I sometimes lean more towards about 6 months. And assuming you're having regular cycles, 6 months if you're 30 or up. If you want to go, full definition, then a year. But again, that's assuming you're having regular cycles. So if you're not having a period every month, then you're probably not ovulating every month. And if you're not ovulating every month, then there's no point in waiting a year. I mean, it's just not it's gonna be much more difficult to happen. So if I have a patient who says, just gonna start trying to get pregnant here and have a period like every 4 months, I'm not gonna say, well, go home and come back in a year if you don't get pregnant, because they probably won't. Type of folks, I'm gonna talk to them right off the top about either Femera or Clomid to try to get them ovulating monthly and go from there. Let's see. Kirsten, how often should I get a pap smear? Is it necessary to go every year? No. So pap smear recommendations have changed. If you are, first off, we don't even start them anymore until 21. So first off, 21 and up is when we start, regardless of when you started having sex. And in your 20s, we do paps every 3 years if they're normal. Once you get into your 30s and above, if your paps remain normal, and we also do the HPV, the human papillomavirus test, if that test is negative, in your 30s, you can go to every 5 years. So those are the new guidelines. So you don't have to have a PAP every year. Now, if you're getting a birth control pill refilled, most places are going to recommend you come in every year for that, just so you can do a quick exam, make sure everything's still okay, and then just refill your meds. And I do that as well. But I don't routinely do pelvics or PAPs on those patients if they're up to date. Okay, so Jordan, 28 regular cycles, trying for 10 months. Yeah, I think you're getting closer, Jordan, and it might be time to start thinking about making an appointment for evaluation. If you want to preview, of kind of the things that I think about when I'm evaluating a new couple with infertility. There's a video on my playlist called Infertility Trying to Conceive, and it's called, I think it's just called Evaluation of Infertility, so maybe check that out on YouTube. And if you don't know, I'll put my YouTube channel name, let me see, can I put a comment in here? I can't, it's not letting me type. Oh, here we go. I can't do it. It's not letting me. But anyway, my YouTube channel name is, just go to YouTube and type in all one word, Wes D Ski, like S-K-I. I like to ski. You'll find it. And then there's a playlist in there called Infertility Trying to Conceive. The videos in that playlist. Cool. Okay, let's see what we've got over here on YouTube. Let's see. Is it safe to wear tight wraps or corsets after delivery? Yeah, I think they're fine. You know, some people call those binders, abdominal binders. They give a little support. I don't think there's any proof that it makes anything go back to normal any faster than if you didn't wear that. But for some people, it just the support feels good. So especially like after C-section, because it just kind of takes a little bit of the pressure off your incision. So I think they're fine. Did I say Femara is better than Clomid? There's some evidence in PCOS that Femara is better than Clomid. Clomid's still fine. It's Femara maybe has a little bit less in the way of side effects, less hot flashes and moodiness and stuff like that. And it may be a little bit more effective at inducing ovulation. It's not to say you can't start with Clomid, because you can. But I often go straight to Femara with patients who have PCOS and aren't ovulating. Let's see. Oh, thanks, Kylie, for typing that in. So Kylie typed in the YouTube name for me. Thanks, West E Ski. That's me. Let's see what we've got here. Leah, a friend recommended cramp bark. I don't even know what that is. I've never heard of it. I have no idea. Couldn't recommend it. But just kind of in the big picture, like people who contract a lot. The bottom line is, you know, if your cervix is long and closed, you know, a lot of times if we have somebody who's kind of frequently coming in with a lot of contractions to the hospital, we'll even do this test called a fetal fibronectin. It's a little vaginal swab. If that fetal fibronectin is negative, the chance of delivering in the next 2 weeks is less than 1%. So we know that's just somebody who's contracting a lot, but not really going to have a baby anytime soon. Really don't worry about it much. But if there are situations where I just contracting tons, it just drives me nuts. I'm really worried. Can't we do something? You know, I will prescribe nifedipine, which is actually a blood pressure pill. It's a calcium channel blocker. It makes smooth muscle relax, and the uterus is just a big smooth muscle. So in some people, it helps reduce the contractions. There's no proof it's going to prevent preterm labor. So if someone's really in preterm labor, it's probably not going to do anything, but it may cut down the contractions. So if you want to try it, you can call the office. We can call it in for you. But dizziness, lightheadedness, headaches, low blood pressure, those are kind of the typical side effects that you might encounter. Okay, Jordan, you're welcome. Let's see, Megan, every time I had sex since pregnant, got a yeast or UTIs, is that normal? What's going on? Should you be worried? It's pretty common. UTIs are fairly common after intercourse. The best thing you can do is get up and pee. So that's the first thing. Empty your bladder, because that's going to flush out any bacteria that may have kind of found their way up inside the bladder, and there's evidence that reduces the risk. If you have documented recurrent UTIs and you've been doing that, maybe try cranberry juice, and we can even do 1 dose of an antibiotic after intercourse. And that seems to help as well for folks who've had like an evaluation, everything's normal, they just keep having them. If it's yeast, specifically because it's yeast or UTI, there's not as simple of a solution for that. And it's kind of more about just good vaginal health in general. So, like maybe trying a probiotic. There's lots of data that, you know, your gut health has a big role on your health in general, and vaginal health is no different. So taking a good probiotic every day might be helpful. So the doorbell's about to ring and my dog's about to go bananas, just so you guys know. All right, let's see. Didi said, which one has a higher chance of twins? You're talking about Clomid versus Femara. You know, honestly, I don't know. They're probably both about the same. I quote folks maybe 2-3% risk of twins. So not too big of a deal either way. And then what's the drug they give for preterm labor? So T, that's terbutaline. And that one's used in the hospital kind of as a shot. And it's often used sort of in the triage process of evaluating somebody who's coming in having a lot of contractions. There it is. There's the bell. Um, and it's, again, it's not going to prevent preterm labor. It's not going to stop preterm labor. But if someone's having a lot of contractions, then it may quiet things down. And if it does, then you can feel pretty confident, like, okay, that patient's not early in labor. She can go home. But Dee Dee, you're right. Side effects, you get red heart, feel kind of nervous and shaky. It's actually an asthma medication, and it's basically adrenaline, so that's why it makes you feel pretty crummy. All right. I think I'm all caught up. Well, the dog didn't go too bananas. He just gave one little bark, so that wasn't too bad. So I think we're all caught up again. I'm just going to take a sip of water. If you guys have questions, throw them in there. Well, not seeing any questions at the moment. Let me know where you're watching from. If you are still on this channel, type in, just put in the comments where you're watching from. I'm really curious to know. I think so far the furthest I've had is Guam. Guam is pretty crazy far out there. And then recently a couple of folks, I think from the UK, and a lot of folks from Layton and Roy and Ogden. And Dee Dee's from Texas. Yep, I knew that one. So yeah, I'm curious to see where everybody else is watching from. Nobody's really jumping in with an answer. Maybe it's take a minute, the delay from when I say it to when it comes up on the screen. Let's see. Pleasant View, there you go. All right, so now, how was it? How come the norm is women give birth laying on their back when there's evidence of one of the worst positions to live away from? From Iowa, hey, welcome. It's a good question. I think the most common reason is with epidurals, that they can be a little positional, and number one, number two, if there's weakness in like your hip flexors or your thighs, it may be kind of hard to support yourself. So it sort of depends on the density of the epidural. If you're talking about an unmedicated delivery, then I think that people kind of deliver in whatever position works. But some of the things that come up are if you suddenly have a difficult delivery, say a shoulder dystocia, then it's helpful to be on your back because they can flex your hips, we can maneuver, stuff like that. So I think it's probably mostly habit, somewhat epidural, and a little bit for difficult deliveries. And that's pretty much it. It's probably just habit more than anything. And I'll say sometimes it's hard. I have delivered a lady squatting, and she was squatting on the floor. I can't remember why. Maybe she just like hit her all of a sudden. And so I was almost like laying down on the floor to catch this baby. That was kind of weird, but it worked. So let's see. Okay, we got Krista says my comments above is not ancient. Let me see if I can find it. Thanks for telling me. Krista. Okay, let's see. Cycles have not been normal since before daughter, almost 3. Haven't been on birth control for almost a year. Not trying to get pregnant. Should be worried. I mean, worried. No, I wouldn't be worried. Is it bothersome? I think that's the bigger question. If it's bothersome because when you finally do have a period, they're heavy, then maybe consider doing something about it. Some sort of hormonal management is the most common answer. If you have somebody who has no periods or very infrequent periods, a few a year, you have to worry a little bit about the risk long-term of endometrial hyperplasia and cancer, stuff like that. So in those situations, especially like your obese PCOS patient who's having 2-3 periods a year, their lifetime risk of uterine cancer is higher. So, if that's the scenario, then I definitely encourage patients, like, we need to do something to get a period going, or put in a progesterone IUD because that'll reverse the effects from the PCOS. But if none of those things are you and you do have periods, but they're just not super regular, then I wouldn't worry about it if it doesn't bother you. Okay, and there was somebody else who said their question wasn't answered. Amber, let me see if I can find your question, Amber. I'm not seeing your question, Amber. I don't know if you don't mind just copy and paste it and stick it back in there, because it may sometimes you can see it on your feed and I can't see it on mine. I've had this happen before. It's just something weird with the live feed. So if you don't mind, just copy and paste it and I will be happy to answer it. Let's see. Amanda says, what are the best ways to manage PCOS? Any new research? It's all about weight loss, diet, physical activity, trying to reverse the metabolic effects that PCOS induces that involve things like insulin resistance, hyperandrogenism, stuff like that. One of the quick ways is just put someone on a birth control pill. It'll help, it'll regulate their periods, it'll cut down on some of the hyperandrogenism type effects, and that's like the facial hair, acne, stuff like that. There's nothing really particularly new when it comes to PCOS, um, but that's kind of the typical stuff that we recommend. Let's see, Krista, when they come to only about 3 days not having out PCOS. Yeah. Oh, when they come, got it. Yeah. Yeah, it doesn't sound bothersome. I mean, I guess the question is how often do they come? If you said 3 times a year, then it's probably worth doing an evaluation, check your thyroid, check some hormone levels, stuff like that. Cool. I think I saw something pop up over here on YouTube. Let's see. Any benefits from encapsulating placenta? Do you recommend it? I don't recommend it. There's no good evidence that there's any benefit. There's lots of internet buzz and people in chat rooms who say, well, I took it and it worked great for me and I'm happy for them. Great. But so far, no well-designed studies have shown any effect in terms of reducing postpartum depression, improving milk supply, any of those things. Now, it does not mean that for an individual patient who took it and had relief, that I think that was a bad thing. It's fine. I don't care. It's not my thing. There is one report, and it's on my YouTube channel, Dangers of Placental Encapsulation. It was reported in JAMA Pediatrics, so a reputable journal, that showed a potential risk of group B strep infection in the neonate. So the theory was that the placenta was not treated correctly, probably bacterial contamination from delivery, and reintroduced that bacteria into the baby because there was a delayed onset of infection. I forget how long, but longer than typically what you would expect. And that baby got seriously sick, like meningitis, ICU, near-death experience. So that's one thing. I get it. That's pretty rare. But to me personally, if there's any risk and there's no proven benefit, I don't know why you'd want to do that. But that's a personal decision. I think with a lot of these things, there's a huge placebo effect, where the power of the mind is a real thing. And if you believe that if you do this thing, it's going to help, it could help. And there's great evidence in the depression literature. If you look at the trials for Zoloft and Paxil and Prozac, all these, the placebo group had a huge response. Now, the medication groups had a better response, but it was still like 20-30% of folks taking Prozac, 20-30% of folks in the placebo group compared to Prozac who also had improved depression symptoms. So it just kind of proves my point that the power of the mind is a real thing, and if you believe it, it may happen. So like I said, I don't really care one way or the other. Somebody wants to do their placenta, go for it. But just no good data to support it at this point, and there are some potential risks. So I just keep that in mind. All right, let's see. Nell says, period was the worst after getting off birth control, 3 periods that year, 6 the following year. This is the 3rd year. She said 1 every month, separate, everyone got cold. Sounds like things are getting better. Not sure if you had a follow-up question to that, but sounds like you're going the right direction. Sorry about knocking the phone over there. Okay, cool. I think I'm all caught up. Carly, your doctors put you on progesterone with both last pregnancies, miscarried, something through that, never fully understand, makes you super sick, would like to understand a little more. So, there's this ongoing quest to try to figure out what can we do to reduce the risk of recurrent miscarriages in somebody who's had repetitive miscarriages. And lots of things have been studied and not many things have panned out. Progesterone is on that list. It's been studied. The data's not really great that it makes a difference. There's plenty of people who had recurrent miscarriages who then used progesterone in a subsequent pregnancy who did not miscarry, and they are convinced it was the progesterone, and I'm happy for them. But the data is just not there. So if someone says to me, I'm taking it, I want to take it, no problem, take it. But if someone says, I'm taking it and I hate it, do you think I really need it? Then I tell them what I said. There's just not great proof. Okay, so Chris, how do you diagnose endometriosis? Do you see it on ultrasound? No. The only way to diagnose endometriosis is surgically. So laparoscopy is the most common way to diagnose endo. You take a patient to the hospital, put them to sleep, put a camera in their belly button, blow the belly button up with gas, and you can see endometriosis. Looks typically like little dark spots. We call them powder burn lesions. They're often not much bigger than the size of a pinhead. They can be one or two, they can be everywhere. It just sort of depends on the severity of the disease. There's other types of lesions as well, but that's the most common. But basically, you can only see it at the time of surgery. Now, you can suspect it based on history, primarily painful periods, pelvic pain, painful intercourse, sometimes infertility. But I will tell you that even in the situation where you have all those things, my experience, about half the time you have endo, about half the time you don't. So I tell every single person that before we go to laparoscopy for what we think might be endo. There's a 50-50 chance you wake up and I tell you it was normal, and then we go, I don't know. So just kind of keep that in mind. It's not wrong to manage the symptoms, assuming it could be endometriosis without surgical confirmation. And then if you're not responding to medication or the pain's getting worse, then maybe considering surgery. And typical medical management is just some type of hormonal treatment, so either birth control pills, NuvaRing, progesterone, IUD, stuff like that. All right, let's see. And no, you're welcome. No. Let's see. I think I'm caught up again. Whew. There was still somebody who said I didn't answer the question. I think I saw it. I think I've looked through the whole list and just don't see it. So if you're still on here and I haven't answered your question, please just copy and paste it. And I'll hopefully it'll pop up this time. There's just something weird about Facebook Live. Sometimes the comments don't come up. I think I had somebody a few weeks ago that did that. And I don't know if it happened live or they may have even been commenting on it during the playback. So, because after the video is over, you can watch it. So it's saved on Facebook, it's saved on YouTube, and you can replay it. And I kind of think that they were watching a replay, and they were just like, I don't know why you won't answer my question. I'm asking like 5 times. So it was either that or it just didn't come through. I don't know which, but it was kind of funny. But sorry if I haven't answered your question. Just try repasting it, and I'll be happy to. Let's see. And Chris, sort of follow up on endometriosis. Once you have it, do you always have it? Probably to some extent. It doesn't mean that it'll always be as bad as it was before. It also could get worse. But I think it is probably one of those things. Now, if you do, definitive surgery for endometriosis, hysterectomy, removing all visible lesions, then it should minimize the chance of it coming back. But I still think there's this possibility for microscopic endometriosis that you can't see at the time of surgery that then kind of grows back over time. I've seen that. I didn't see it obviously on the first pass, but did a hysterectomy. Patient came back in pain like a year or two later, re-scoped her and found a couple more lesions that were in an area that I had looked, and I had pictures where I could see, look right here, there was nothing back then, and now there was. So I think that it certainly can sort of develop back over time. But we think the primary way that you get endometriosis in the first place is what's called retrograde menstruation. So when you have your period, some of that blood can drip out through the tubes and implant into the pelvis. And in that blood is the endometrial tissue, and that's what causes endometriosis. So the big thing is if you can suppress your period, you probably suppress further regrowth and new growth of endometriosis. All right, cool. Let's see, something popped up over here. Let's see, 20 weeks pregnant, concert coming up soon, is loud music. Yeah, I think it's fine. There's no evidence of any ill effects for a baby where the mom went to a concert or whatever. So I think it's fine. And July 4th is coming up. There's going to be fireworks. I think it's fine. So I wouldn't worry about that. Let's see. Other question is endo pain just noticeable during the period? That's when it's most common. So you may have pelvic pain every day, but it's worse with your period. Or you may not have pain every day, but you have it with your period. But the kicker is that it's worse or present with your period. So that's one of the things. But there's plenty of people who don't have endometriosis who have painful periods. So kind of like I was saying, about half the time you look and there's just nothing. Okay, so we've been going. Gosh, it seems like 5 minutes. It's been 50 that we've been streaming. We'll probably go about 10 more minutes and then cut down for the day. Or shut down for the day. So if you have questions, throw them in there. I'll be happy to answer them. And if you haven't already, check out the YouTube channel. I know you do if you're on YouTube. But if you're on Facebook, I think a lot of people just see me on Facebook from the office Facebook page and don't realize that I have a YouTube channel. There's like 100 and some videos up there now. My advice, if you're pregnant or thinking about getting pregnant, check it out because answers to a lot of these questions, not all of them, but a lot of them are on there. So let's see. Might have missed one over here. Alexis, friend trying to get pregnant. Her period was on the 16th last month. When can she try? So, typically you ovulate about 2 weeks after the first day of your last period. That's not exact, but it gives you a ballpark. But what I would recommend to your friend is check out the video on my YouTube channel. It's under the infertility / trying to conceive playlist, and it's called Maximizing Your Natural Fertility. It does talk about ovulation monitoring, cervical mucus, and a lot of other things, timing of intercourse, frequency of intercourse, stuff like that. So I would check that out. All right, let's see. Can fibroids prevent pregnancy? They can if they're in the wrong spot. So if you have a fibroid in the cavity of the uterus, they can absolutely cause problems for fertility. So that's called a submucosal fibroid or an intracavitary fibroid. Yeah, if you got those, it's going to be not necessarily impossible, but it's going to be hard to get pregnant. So those should be treated. Now, if you have fibroids outside the cavity of the uterus that are not distorting the cavity in any way and are not blocking a tube, then I don't think that they're of any concern, and we don't recommend treating those just for fertility benefits. You'd only recommend treating those outside the cavity for, either heavy bleeding or pain. Cool. All right, I think I'm caught up again. Let's see, if they get removed, would that solve it? If you have a submucosal fibroid, and if everything else is normal, sperm are normal, tubes aren't blocked, ovulating, everything else looks fine, and you have an intracavitary fibroid, it's got to help. So if that's going on, I would definitely recommend a patient to consider surgery for that. And the good news is it's fairly minimally invasive, so we just put a little camera up through the cervix and use one of a couple different types of devices to either kind of chomp that fibroid up or cut it out with an electrical loop. Depends on what the hospital has, where the doctor is. Let's see, is it common to have both PCOS and endometriosis? It definitely happens. I don't have a number off the top of my head to tell you what the percentage is, but they're both fairly common entities, so it wouldn't be a big shocker if somebody had both, for sure. All right, so I think we'll probably go about 5 more minutes or so here, and then we'll call it good for this Friday. I was looking to see, I saw some Utah people here out at Syracuse, Layton, Pleasant View. So far, Dee Dee's the winner, Texas. Kylie asked, what age are you supposed to start PAPs? Talk about that. Maybe, I don't know if you heard that one or not, but 21 is when you start them. I think I'm all caught up. I don't see any questions I haven't answered. Okay, we'll give this another couple minutes. I'm not seeing any more questions rolling in. There's still people on here. I can see there are eyeballs on both broadcasts, so there's still people watching. If you've got a question, now's your time, because I'm fully caught up and looking for something to talk about. Okay, let's see. Alexis, question about your classical C-section. Doctor said coming out. Okay. Question about my classical C-section. My doctor said if she is coming out the vaginal area, I guess, then I can have vaginal delivery. Well, yeah, I mean, I've had that happen. I had a patient basically deliver in the elevator, and we knew she was coming because she had that history, and I was basically there waiting for her, and she rolled in and had a baby. So yeah, great for her. I would not recommend laboring at home with a classical C-section because you're trying to just basically roll in and have a baby. However, we know the risk is higher for uterine rupture in people who've had a classical uterine incision. It's so low transverse, 1 prior C-section, it's about 1%. If you've had 2, it's about 2%. If you've had a classical, I've read studies where the risk goes up to 12%, and it may be higher. We don't know. So I wouldn't recommend laboring with a prior classical C-section because the risk of uterine rupture is at least 10 or 12 times higher than normal, and it can be life-threatening for mom and baby. To my opinion, just not worth it. I'm all about vaginal birth after C-section. If it's low transverse, 1 or 2 previous scars. I just delivered somebody who had 2 previous C-sections this week, and she did great. Okay, and the same day I had somebody delivered with 1 prior C-section. Let's see. What about recurrent HPV? The only time it went away was in 6 weeks of no sex after baby. What can be done? Should you worry? The main thing that you worry about is persistent high-risk HPV. So 16 and 18 are the 2 most carcinogenic HPV strains. People who have persistent HPV 16 and 18 are definitely higher risk for cervical cancer. I've diagnosed a couple in the last year, and in both cases, that was the story. They never had severely bad PAPs. It was always kind of mild stuff. But then ultimately, through persistent reevaluation, and we figured it out, and that's what it was. Now, did it progress? Was it there the whole time? Who knows? So I think the most important thing is if there is persistent HPV, especially 16 or 18, then you should definitely follow up. It's typically yearly, perhaps maybe every 6 months, depending. Let's see, Amber, are you taking new patients? Yep, I sure am. You can call the office, 801-337-5800, and make an appointment. Happy to see you. Let's see, Jess, horrible taste in your mouth first trimester. How do you get rid of it, or will it go away? It'll probably just go away. How do you get rid of it is a harder question. You know, all the things you've probably already thought of, like, you know, hard candy, drinking lots of water, brush your teeth frequently. That may be bad too because it may make your nausea worse. But just trying to change the environment there a little bit maybe helps. But it typically just goes away on its own. And for some people, that's kind of their nausea. It's just this weird taste. Some people, their nausea is just they spit a lot. That's called tylism. And so that's another one too. Julia, hey Julia, 17 weeks. Is it safe to take Unisom B6? Totally safe. You can take it every day, the whole pregnancy. It's fine. There's like over 50 years of data on the 2 components. That's vitamin B6 and Unisom, which is doxylamine. There's over 50 years of data that shows it is safe. So I don't see any reason why you can't take it every day. Cool. Okay. I think we're caught up. I'll give another minute or so. What can be done? Oh, I think that's me. Well, Dee Dee just saying, I think that might be you. The big thing is just, do the follow-ups. Keep getting your PAPs. Keep doing the colpos. And is HPV 16 or 18 persistent with abnormals? It's not wrong to consider doing a LEAP where you just take a bigger chunk of the cervix out. Yeah, you read my mind. We have this connection. So yeah, maybe you consider a LEAP, particularly if it's been like, a few years persistent and it's unexplained. Because one concern is, well, is it a little higher up in the cervical canal? Like you're not seeing it on the outside. I always do endocervical curettage. Yeah, it's fine to do. I would maybe consider it. Endocervical curettage where you scrape the inside of the cervix up in the canal to try to sample that area where you're not getting it from PAPs or colpos. So it's worth at least a conversation for sure. Okay, and especially when you're done having kids, because there's like, what's the downside? Let's see, Katie, risk of back-to-back pregnancies less than 9 months in between. Honestly, not too big of a deal. I think if it was a major deal breaker, nature would prevent it. I think the main things are, number one, you may or may not have gotten all the baby weight off from the first one, so that puts you at risk for gaining too much weight in the second one, which does have an associated risk of C-section, so you just want to be careful with the weight gain. It could obviously interfere with nursing. A lot of times the hormones of pregnancy, once you get pregnant, then you may not have as much milk supply, so that may kind of force you to wean. But aside from those 2 things, I don't think there's tons of data that really there's any major risks. So I generally reassure patients, and my experience has been they do fine, so I wouldn't worry about it. Cool. Okay. I think that we are about done. It's been an hour. It blew by, like it always does. Thanks to everybody who has watched, who is still watching. There's eyeballs still on both screens. I really enjoy doing this. This is like my thing on Fridays. Everybody knows it now in the office. I'm rounding on patients all the time in the hospital who aren't my patient. Like, oh, I saw you on Facebook, or I saw you on YouTube. It's super fun. I really enjoy it. So thanks to everyone. Thanks, Dee Dee. It's good talking to you as always. So I should be back next Friday. I'm on call. It's a holiday weekend. Who knows how busy it'll be? But if it's not that busy, then I'll be back next Friday between 2, 3 o'clock, somewhere like that, Mountain Standard Time for those of you not in this time zone. And thanks again for everybody for watching. Have a great weekend, and we'll see you next time.